This lecture will focus on muscle relaxants. And by that we mean drugs that are specifically trying to affect skeletal muscle that is hyperexcitable. So our primary goal of the drugs we're about to meet is to be selective in that we're trying to decrease the excitability of skeletal muscle, which isn't hard to do. It's easy to decrease muscle excitability with various medications, but we want to do this to the muscles that are too excitable, ideally without affecting the muscles that are normal. So we're going to subcategorize these drugs into two primary uses. First being drugs that treat muscle spasms, and I'll define what I mean by a muscle spasm, as compared to drugs that are used to treat spasticity. So increased skeletal muscle excitability. What we're often talking about now is conditions such as muscle spasms, and I'm defining spasm as an injury usually directly to the muscle itself, or even more likely, pressure or injury to the peripheral nerve that supplies that muscle. I only see this characteristically with things like herniated discs pressing on nerve roots, for instance the L5 or the L4 nerve root, causing paraspinal spasms, or injuries to some of the cervical nerves, causing spasm in some of the neck and upper back muscles. And of course, what we see oftentimes is these spasms are tonic. They're very solid. They're not velocity dependent, and the muscle itself is very strongly contracted. This is contrasted with spasticity, where the lesion is not to the peripheral nerve, it's to the central nervous system. For things like a spinal cord injury, or cerebral palsy, or a cerebrovascular accident, or multiple sclerosis. And it's a very complicated phenomenon, but we can summarize spasticity often by focusing on an exaggerated or a hyperactive stretch reflex, where supraspinal control of the stretch reflex has been interrupted or damaged in some way, so that we see this velocity-dependent increase in muscle tension. And if we slowly try to extend the extremity with the spastic muscle, that it often can be fully extended or fully flexed depending on the type of spasticity. But if we try to do this rapidly, we get this sudden increase in time. So first we're going to focus on the muscle spasm drugs. And we'll start by talking about a pretty diverse or eclectic group of drugs that, for lack of a better term, we'll call centrally acting antispasm drugs, because as you'll see, they tend to work in the central nervous system. Then talk about a specific drug known as Valium, a very well-known drug, often used for many different situations. But first, the centrally acting antispasm drugs. So we're talking now about these centrally acting antispasm drugs, which, as I said, are fairly diverse and eclectic in terms of their similarity. They're not very similar to one another. And they're used commonly in back spasms, neck spasms, and various orthopedic injuries that lead to that tonic, hardened muscle contraction that we classically see again in the paraspinals, the trapezius, the levator, the rhomboids. And again, we're going to take a look at these drugs and talk about how they work. So what are the common antispasm drugs we're talking about right now? Common one is crisaprotol, often known as Soma, chlorzoxazone, Paraflex, Parafon Forte, if it is combined with aspirin. It often uses that trade name. Cyclobenzaprine, Flexeril, very well known to any kind of, many clinicians working in orthopedic or even outpatient therapy know this drug pretty well. Scalaxin, same thing. Methocarbamol, you can see the trade names here, all referring somewhat to the effect on muscle flexibility or relaxation. Norepinephrine. So it's not an extensive group of drugs, and as I said, they're not really very similar at all chemically to one another, which begs the question, then why do they all share this common goal of treating muscle spasm? So the possible mechanism of action of these drugs has been really studied for some time. And we know that certain drugs like crisaprotol, one of the key members of this group, enhances the GABA ability to inhibit neuronal activity in the brain. And we talk about GABA receptors, and we're going to talk a little bit more about GABA as we talk about other drugs in this section, like Valium. But GABA is, of course, a very important inhibitory neurotransmitter, probably the most common inhibitory neurotransmitter throughout the central nervous system. There are two types of GABA receptors, at least two types. GABA A, which is more predominant in the brain, and GABA B, which is more predominant in the spinal cord. By inhibiting GABA A, we would get this effect of this drug. A second drug, cyclobenzaprine, seems to increase serotonin activity in the brainstem. And again, serotonin, a very complex and a very common neurotransmitter throughout the central nervous system, serotonin tends to be inhibitory. So we're seeing possibly an increase in the inhibitory effects of serotonin in the brainstem. For the other ones in this group, we really don't know how they work. So why are they effective in treating muscle spasm, or how do they share this common goal of treating muscle spasm? They're all strong sedatives. And we know this is an effect of the drugs you see listed here, like crisaprotol and cyclobenzaprine. By increasing the effects of GABA or serotonin, we're going to get more sedation. And the other drugs probably work very similarly, either using the similar chemicals or other chemicals that do cause sedation in the central nervous system. And the question then is this really their primary effect? In other words, they don't really affect the muscle directly, but by increasing the level of sedation throughout the central nervous system, from the cortex down through the cord level, brainstem and cord level, we're simply getting less excitation of the alpha motor neuron. And if that happens, then the muscle will relax. And this is probably their primary effect. So again, as muscle relaxants, so the bottom line on the antispasm drugs is that they're going to probably work, especially in acute muscle spasms. Short-term use may be beneficial. We know this if we do randomized controlled trials and half the people get the drug and half the people get a placebo, we'll see decreased pain, increased range of motion, increased flexibility in the group getting the drug. So we're not saying they don't work, but if they do work, they work by this sedative effect. So patients often self-select or independently select to take the drug at bedtime, only at bedtime, because of the strong sedative potential. And you'll have patients say to you commonly, I can't take this drug during the day. I have to go to work. I have to take care of my family. So it's not uncommon at all to have a patient, regardless of what the original prescription is, to say, I'll take it at bedtime. This is not a bad idea because the patient's going to sleep better, possibly. Maybe the muscle will relax as they're sleeping and cause perfusion of the muscle to wash out any metabolic buildup, and maybe decrease any kind of a pain spasm cycle that may be occurring. But again, it's uncanny how many patients independently decide to do this, even if they're not told to do this. And ideally, the drug therapy should be combined with aggressive physical therapy, manual therapy techniques, exercise techniques, physical agents as indicated. Ideally, then, we can take the drug away and maintain the antispasm effect through our physical therapy interventions. So the best case scenario is to start aggressive physical therapy with the drugs at the same time, and then discontinue the drugs after a very short time, possibly only 3 or 4 days. These drugs are certainly not meant to be used long term. And so that was our group of what we called centrally acting drugs. Now we're going to talk about a specific drug called Valium, or its generic name, diazepam. This drug, of course, was developed originally as an anti-anxiety drug. We'll see it when we talk about psychotropic medications as one of the really premier anti-anxiety drugs. And it is probably the most famous member of this class of drugs called the benzodiazepines, or a lot of people refer to them simply as benzos. It's a complex drug. It's a very interesting drug. It works in the central nervous system to increase the inhibitory effects of GABA, and that effect has been studied very carefully, and we'll talk more about exactly how it does this. GABA, as I mentioned a minute ago, is the most common, probably the most important inhibitory neurotransmitter that affects receptors throughout the brain and the spinal cord. So we want to take a closer look at the way GABA works. That'll give us some insight into how drugs like Valium. So we're going to take a look now at a schematic representation of the benzodiazepine receptor. And what you're looking at is the phospholipid bilayer in a neuron somewhere in the central nervous system. Then embedded in this phospholipid bilayer is this large protein, the benzodiazepine receptor. And you can see that this protein has binding sites on its outer surface for several chemicals. Certainly has a binding site for GABA, the so-called alpha binding site, but it also has binding sites for the benzodiazepines, these gamma binding sites. The beta binding site is probably specific for barbiturates and maybe even other chemicals. So there certainly seem to be various chemicals that can moderate the activity of this receptor. Now down on the right-hand part of this diagram, you see that down the center of this protein is a channel, or an opening, that's specific for chloride ions. And this channel is shown closed here, but it can open when stimulated appropriately by one of these chemicals. We're going to take another look at this, our more schematic representation of how these. So here's a more, again, basic diagram of what you just saw. Phospholipid bilayer, or the neuronal membrane, goes horizontally across the diagram, and in the center you have this large protein. And as we said, GABA is a neurotransmitter. It's produced by neurons that influence this receptor in the nervous system. When GABA binds to its binding site on the receptor, the chloride channel opens and chloride enters the neuron. Chloride in most neurons in the nervous system is inhibitory. As more chloride enters the neuron, the interior aspect of the neuron gets more negative, and it's typically harder to excite. So that's how GABA causes inhibition in neurons in the CNS. Now we want to look at what happens. So here again, same diagram, but now Valium is also on the scene. And Valium represents, as I said, this family called the benzodiazepines, but we're focusing right now specifically on this drug and how it might cause muscle relaxation. So now Valium shows up and binds to its binding site, which causes GABA to bind more strongly and have a longer lasting effect. So the drug Valium causes the transmitter to bind stronger and last longer, which opens the chloride channel and allows more chloride to enter the neuron. If more chloride enters, there's going to be more inhibition. And this explains how drugs like Valium work regardless of their use. They always work this way. Right now we're talking about how this drug might be used as a muscle relaxant. As we get more inhibition in the spinal cord, we get less excitation of the alpha motor neuron that supplies the muscle. And that's how the drug works as a muscle relaxant. More inhibition of the alpha motor neuron causes less excitation of the muscle supplied. This summarizes what that diagram just showed, what we were just talking about. Valium increases the GABA-mediated inhibition, the inhibition of the alpha motor neuron caused by GABA. Valium makes GABA work better. As we get more inhibition, there's less excitation going out to the muscle, and the muscle relaxes. The drawback is Valium is used to treat both spasm and spasticity. We're still talking specifically now about spasms, but we will see in a second it may be useful also in spasticity. Unfortunately, you're going to have to probably use enough dose, or high enough dose, that there will also be some sedation. And that's really the drawback to long-term use. Still, Valium in short term may be helpful in spasm. And possibly, as we'll see, may
press pause and read this slide before proceeding to the next one for the answer.
So here we go with our agents used to treat spasticity. Again, spasticity being due to an increased stretch reflex activity subsequent to a central nervous system injury. And we'll go through this list, starting again to say a few final comments about Valium or diazepam, and then we'll talk about some other interventions that are very common in spasticity, like baclofen, the alpha-2 agonists, gabapentin, dantrium or dantrolene, and then finally botulinum toxin or Botox. So a few final words about Valium. In this context, as we said earlier, it does act in the central nervous system to increase GABA-mediated inhibition. And similar to its use in spasms, an antispasticity dose will probably cause some sedation. To use enough of the drug to decrease spasticity, some sedation is almost invariable. Long-term use is also limited by tolerance and dependence, or what we commonly associate with addiction. And we know this. The dose will probably have to be increased progressively at some point. That's tolerance. And if you suddenly withdraw the drug after extended use, more than a month or two, there will be some level of withdrawal from the drug. That has to be done carefully. So use in spasticity is not extensive, but it may be helpful if the person has this comorbidity of spasticity and anxiety. We see this in pharmacology quite often. If you can use one drug to treat two different problems, you're really getting a double benefit from that drug. So this is not uncommon, right? If a patient has spasticity, which leads us to this drug called baclofen. And baclofen is really a synthetic form of our own transmitter, GABA. If drugs like Valium increase the effects of GABA, it makes sense that we would try to develop or synthesize a drug that works just like GABA, and that's what baclofen is. Its chemical name is p-chlorophenyl GABA. And its job is to stimulate the GABA receptors in the central nervous system, preferably in the spinal cord. So as I mentioned, there are GABA-A receptors. They tend to predominate in the brain. GABA-B tends to predominate more in the cord. And there's a lot of overlap. It's not like you just have GABA-B type receptors in the cord. But if we've got more of a tendency to stimulate those receptors, we may get more of a spinal cord related effect, which is good. That's what we're trying to do, as compared to a higher effect in the brain, which is going to lead to more sedation. Still, we're going to have an effect on the alpha motor neuron regardless of where you're inhibiting the central nervous system. But if we can have more of an effect on the cord, that's going to give us more of this ability to decrease excitation of the alpha motor neuron, which will cause relaxation. The problem, and you can give baclofen orally. It's a small amino acid derivative, so it gets absorbed easily from the GI tract, it gets into the bloodstream, and it gets into the spinal cord. Unfortunately, again, you have to oftentimes use a lot of it. The dose has to be high enough to control spasticity, that some of that drug will reach the brain, and there will be some level of sedation. Dose dependent, of course, but oftentimes there is some level of sedation, which can often be somewhat limiting. So we're seeing a situation here where it would be really nice if we could give the drug more directly to the area outside the spinal cord rather than send it throughout the entire body via the systemic circulation. And that led to the development of what we call now intrathecal, spinal, subarachnoid all mean the same thing. You're seeing here a diagram of the spinal cord on the left, and as we know, it's surrounded by three layers of tissue, the meningeal layers. The pia mater is the inner layer, the arachnoid layer is in the middle, and the dura mater, the tougher layer, is on the outside. What we're concerned about is putting the drug into this space between the arachnoid layer and the pia mater that we refer to as the subarachnoid space. So the idea is, if you can administer the drug into this area, it can then penetrate through the pia mater and bathe the spinal cord in the drug. Now, some of the drug will get washed away, some of it will migrate upwards and downwards through the subarachnoid space, no question, but most of it does not. Most of it stays where you put it. And this is incredibly beneficial. You'll get better effects using less drug and therefore less side effects. Now, of course, this technique of injecting the drug into the subarachnoid space is understandably difficult and can't be done several times a day. But if you have a patient that responds well to oral baclofen in terms of an anti-spasticity effect, but is being the use is being limited by sedation, this might be a candidate to consider possible intrathecal administration of the drug. So what's typically done is a trial injection. Does it really work? And this will be done through one injection from outside the body into the subarachnoid space by obviously an experienced practitioner. And then we as physical therapists are often monitoring the patient's response to that trial injection. Does it work? Does it look like this might be a beneficial treatment? If so, they may plant a temporary catheter into the subarachnoid space. So once again, what we're thinking here is we have this patient that has moderate to severe spasticity that often responds well to the oral form of this drug, but we have to use a lot of it. And there are side effects like sedation. If so, and if this person responds well to the trial injections I was describing, a catheter with a pump system is usually implanted surgically to deliver the drug into the subarachnoid space. The goal being to decrease the spasticity with less drug, and therefore. So here's a picture of an intrathecal baclofen pump. You get a sense of the size of the pump compared to this person's hand. And you see the pump is basically hollow, and there are electronics in there, and it can be refilled through the port that's on the surface of the drug, right through the skin. There's another port leading out of the top of the pump that is connected to a small tube or catheter that snakes around the patient's thorax and into their subarachnoid space. So the pump is usually implanted in the lower abdominal wall, left or right, with again the tip of the catheter being inserted into the subarachnoid space, often below the L10 level, where the actual spinal cord tissue ends and the cauda equina begins. But still, we're trying to administer this drug more directly to the spinal cord area to get better effects without sending the drug through the circulation to every other tissue in the body, including the brain. And as I said, these pumps, they are controlled electronically. They're very superficial. And if you've seen a patient with a pump, you'll see it right under the surface of the skin in the lower abdominal wall. It can be refilled, as I said, right through the skin when it runs out. And there's this period of time, of course, where we're trying to adjust the dosage based on that patient's needs. Understandably, this is complicated. This is a difficult procedure, and There are technological issues. Pumps can fail, they can malfunction, the tube that supplies the drug can get clogged up or can actually cause meningeal tears. So this is an option for some patients, and in some patients they do really well. So if you have a patient with an intrathecal baclofen system, you should be alert for the fact that the pump may malfunction and supply too much drug, and we're looking for signs of overdose. For instance, patients will start breathing more slowly. Respiration will decrease. Tidal volume will decrease. And we'll see this in terms of, again, cyanotic effects. The coloring becomes more cyanotic, or even pulse oxygenation starts to drop. Cardiac function also is suppressed. Heart rate decreases. Cardiac pumping ability decreases. Patients start to become less responsive and stuporous, which can even progress to coma. The other extreme is if the pump suddenly stops supplying the drug. As a patient that's had the pump implanted for several weeks, and maybe the catheter, the tubing becomes kinked or clogged, or the pump itself simply shuts down. Patients will go into withdrawal, and now we're seeing sort of an excitation. Lack of the drug leads to fever. Patients get confused and agitated. They may start to hallucinate, which can also, again, progress to seizures. So we're kind of seeing two extremes here. Too much drug, too much suppression of cardiac, respiratory, and other functions. So that was baclofen and this technique of intrathecal baclofen. Now, alpha-2 agonists, we have to explain what the title refers to here. An agonist, again, is a drug that stimulates a receptor, in this case the alpha-2 type of receptor. And what we see in the cardiovascular system and in the respiratory system are these alpha and beta receptors. And we'll see alpha-1 receptors are important in the peripheral vasculature. Beta-1 receptors are important in the heart. Beta-2 receptors are important in the lungs. But these alpha-2 receptors they're the oddballs because they're found in the central nervous system. And when you stimulate these receptors, it causes inhibition of neurons. So that's what we're talking about. And the primary agent in this group is a drug called tizanidine, or Xanaflex. And it does stimulate, as the name says, the alpha-2 receptors that are located specifically in spinal interneurons. And of course, we have in small neurons connecting other synaptic activity within the spinal cord itself. So by stimulating these neurons, we're going to get less excitation. The goal being to decrease the excitatory input onto the alpha motor neuron so that there's less outflow from this alpha motor neuron out to the muscle. These drugs seem to be about as effective as oral baclofen, but perhaps less generalized muscle weakness, meaning they do have the. So here's a schematic representation of the spinal cord, and you can see, of course, at the top there's a lot of afferent input from various sources: the stretch reflex, other muscle receptors, joint receptors, and some of this feedback leads through these smaller interneurons. You see 3 interneurons in this diagram that return the activity back to the alpha motor neuron. The drug itself, tizanidine, is binding to alpha-2 receptors on these interneurons. And when it does so, it inhibits their activity. By inhibiting the activity of the small neurons, we inhibit the activity of this large alpha motor neuron. So there's less outflow to the muscle, and eventually the muscle itself is inhibited. So tizanidine is available. It is helpful in some patients, and it's another example of a drug that might be a part of their antispasticity treatment. It doesn't solve the problem in every patient, but it is an option. It might be combined with. Now, gabapentin, the name implies it affects GABA in some way. Its trade name is Neurontin. It was actually developed originally to treat seizures. And in the lecture on seizures, we'll talk about gabapentin and similar drugs and how they were and why they're important in treating seizures. But it was discovered that it may actually help also in muscle spasticity. It works by inhibiting the entry of calcium into presynaptic terminals that release an excitatory transmitter called glutamate. If there's less release of glutamate, there's less excitation in the cord, which we're seeing a common theme here. We're seeing that less excitation is a good thing. We're trying to decrease the excitability, especially of the alpha motor neurons that supply the muscle. It seems to be more helpful in people with cord-related spasticity, things like multiple sclerosis and spinal cord injury. It may cause sedation, dizziness, ataxia. Obviously, it's got the potential for these side effects. And it's not the most common drug you'll probably see used to treat spasticity, but again, a possibility that it may work well in some patients, possibly as part of a more comprehensive drug treatment of this problem. Now, this drug, dantrolene sodium, or its trade name Dantrium, it's actually a very interesting drug because it's the only type of antispasticity medication that directly affects the skeletal muscle. All the drugs we've seen so far in treatment of spasticity have affected the central nervous system, preferably at the cord level, but still within the central nervous system. This drug goes directly into skeletal muscle, where it inhibits the release of calcium from the skeletal muscle sarcoplasmic reticulum. And this is the site at which where calcium is stored and then released from its storage sites in the SR to activate actin and myosin interaction. And this is a common strategy. If we have more calcium, and this is true for any kind of muscle. We're talking now about skeletal muscle, but it's also true for cardiac striated muscle. It's true for smooth muscle. If you have more calcium present in the muscle, you're going to get more interaction of actin and myosin, and you'll get a stronger contraction. We're trying to do the opposite here. Less calcium, less strong contraction. It was developed originally to treat spasticity, but some patients did have problems with liver toxicity, especially women over age 35. And we're not sure why. But this did take away some of the benefit of the drug, and there was more concern about widespread use. It is still available, and it's not used commonly, but it possibly could be used more often, again, with the. So here's a diagram of how this drug works, and you're looking at towards the top of the diagram, we have the storage site called the sarcoplasmic reticulum that stores calcium in skeletal muscle, and there are doorways or channels that open to allow this calcium to come out of the storage site when the muscle cell is excited. And towards the bottom, you see the thick and thin filaments that make up the sarcomere. The thick filaments obviously containing myosin, the thin filaments containing actin. What Dantrium does is it binds to these doorways, these channels, and blocks them. And it's fairly specific for skeletal muscle. It doesn't tend to have much effect on cardiac or smooth muscle. But at the right dose, we want to block a few of these channels. If less calcium is released, there'll be less activation of actin and myosin, and therefore the contraction won't be as strong. So that we know how this drug works, and you can see that this would be a very nice direct effect on skeletal muscle. As I mentioned a minute ago, it's not used extensively anymore. And
press pause and read this slide before proceeding to the next one for the answer.
Now, our final intervention in this group of antispasticity drugs is botulinum toxin. This is, of course, a neurotoxin that causes paralysis of skeletal muscle. And we wouldn't want to inject this systemically, but it has been injected locally to treat severe spasms such as torticollis or laryngeal spasms, blepharospasms around the eye. So the intervention itself is not new, but we have seen more interest in using this possibly to treat spasticity by injecting it directly into the spastic muscle. There are actually 7 serotypes of this toxin. We've synthesized and purified 2 to be used clinically. Type A goes under the trade name of Botox, Dysport, Xeomin, and type B, which is a different potency and a different serotype, goes under the trade name Myoblock. The reason it works and the reason it So here's a schematic example of how botulinum toxin inhibits skeletal muscle. And what you see is the presynaptic terminal towards the top of the diagram, and the presynaptic terminal contains vesicles that in turn contain acetylcholine, which is of course the neurotransmitter at the skeletal neuromuscular junction. Towards the bottom we have the muscle cell itself, which contains receptor area for this chemical, where there are proteins that are specific for acetylcholine. And when an action potential arrives at the presynaptic terminal, there are small proteins called connection proteins. And these proteins, they draw the vesicles to the presynaptic membrane, where they then fuse and release by exocytosis their content, the acetylcholine transmitter, into the synaptic cleft, where it can then excite acetylcholine receptors on the postsynaptic membrane, which leads to an action potential in the muscle cell. So here's the same diagram of the neuromuscular junction. You can see the vesicles and the connection proteins are in place. But if botulinum toxin shows up at this presynaptic terminal, it is actually drawn directly into the presynaptic terminal. It's a very specific effect. And then it's a protease. It literally eats up these connection proteins. And if the proteins are not there, when an action potential does arrive at the presynaptic terminal, nothing happens. You can't release the vesicle or fuse the vesicle without those proteins. So that's how botulinum toxin inhibits skeletal muscle function. So in terms of its antispasticity effects, the idea is to inject the toxin directly into selected muscles. And as we'll see, this is the muscle that probably needs the drug the most, that's the most problematic. And if it works, relaxation and paralysis will occur usually within a couple of days. We think it takes a few days for the toxin to actually get into the presynaptic terminal and exert the effects you just saw. The effects often last about 2 to 3 months, and people will say, well, Botox injections or botulinum toxin injections wear off. They don't really wear off. What happens is the presynaptic terminal recovers. It literally sprouts a new presynaptic terminal that grows down and attaches to the muscle cell and forms a new neuromuscular junction. And this takes about 2 to 3 months to occur. When it does occur, we of course need to do a second set of injections and start the process all over again. So the toxin doesn't really wear off. The neuron actually actually recovers. But the good news is, while the drug is in effect, we may reduce spastic dominance, and ideally this can actually increase residual function. For instance, a patient, maybe a child with cerebral palsy that has severe adductor spasticity in their leg and has a scissoring gait, if we can eliminate that, gait may be dramatically improved. But even if we can't increase residual function, patients may simply have better ADL. Patients, say, with severe flexor spasticity in the upper extremity, by injecting it into the wrist and finger flexors, we may be able to get better range of motion of the hand, better cleansing. Braces may fit better. Classic is a patient that needs an AFO on their lower extremity, but if they have severe plantar flexion. Now, other effects. This current idea is that botulinum toxin, as it enters the presynaptic terminal, may actually be transported upstream through the alpha motor neuron via retrograde axoplasmic flow into the central nervous system. If this happens, we may see more of a carryover or long-term effect. In other words, it may have a more lasting effect on excitability and reduce excitability. And this idea is still experimental or theoretical to some extent, but it is a possibility. We know that things that enter the presynaptic terminal can be carried upstream, as I said, back into the central nervous system, and when there, may have more of a lasting effect on the overall excitability. Now, problems and limitations of botulinum toxin. Clearly, we should be concerned. This sounds like a very serious intervention, and it certainly is. Some people may show a local irritation at the injection site, some redness or inflammation. It's understandable considering this is a toxin. More serious is the idea that the body sees the toxin and develops antibodies to it. This may be due to other components that are mixed in with the toxin itself as it's prepared to be used clinically. But still, the problem is if the immune system develops antibodies, when you inject subsequent doses of the drug, they won't work because the immune system will have antibodies that inactivate the toxin before it has a chance to do its therapeutic benefits. As a result, we typically must limit the total dose. In an adult, this is probably about 300 to 400 units of the type A form of the toxin. Different potency for the type B, but still a limitation of 2,500 to 5,000 units of the type B toxin. What this really means is you do not have enough of the toxin to affect every muscle that you possibly want to affect. If a person has hemiplegia from a stroke, you can inject all the spastic muscles in the upper extremity and lower extremity. So what it really requires is careful consideration. What is our primary goal of doing this treatment? Which muscles need this drug the most? And in a lot of situations, the patient, physical therapist, maybe the occupational therapist, patient's family, and the physician should all sit down together and talk about this and say, what's our best case scenario? What would we hope to achieve? Maybe it's controlling the lower extremity to improve gait or make gait safer, but maybe it's not. Maybe it's more the upper extremity. Likewise, there are other problems. If any of this toxin does find its way into the systemic circulation, maybe it's injected very close to a capillary system, we may see signs of overdose. Watch for your patients to have drooping eyes. They can't quite get their eyes open. Or difficulty speaking and swallowing. The vocal muscles are affected, obviously, and the swallowing muscles. Or much more generalized muscle weakness. We like this toxin to stay put in the muscle where it's injected, but again, for some reason it's found its way into a more general circulation. Respiratory distress. The respiratory muscles now are being inhibited, and patients are have dyspnea, they're difficult, labored breathing, they become more cyanotic, and their pulse oximetry begins to fall. So be very careful. Watch for the.
Press pause and read this slide before proceeding to the next one for the answer.
So let's summarize our major concerns about the muscle relaxants. Now consider we've just seen a pretty vast array of different drugs used for different problems, but still we can summarize this in a couple of key aspects. First being, some of the drugs and some of the interventions we saw can cause weakness in other muscles that are not spastic or cause generalized weakness. And this can be devastating. Let's say, for example, you have a patient with lower extremity spasticity, possibly due to a spinal cord injury. This patient needs good upper body strength to transfer, perform ADL activities, use a wheelchair, and so forth. And if we take away some of that upper extremity strength, it could be pretty harmful to the patient's outcomes. So we're always trying to find the middle ground of a dose of the drug that will preferentially decrease the spasticity without removing some of the beneficial or necessary strength in the non-spastic muscles. We saw that many of these interventions can cause some sedation, and dosage here is likewise important. That some of these drugs, that we're trying to find a dose of the drug that decreases the spasticity without causing excessive sedation. But it can be quite problematic, and the dose that we're looking for, there's a small margin of error. In other words, it doesn't take a big dose over the antispasticity dose that causes sedation. And perhaps most important for us as clinicians, some of these interventions can cause a dramatic change or drastic change in muscle tone over a relatively short period of time. The best example are interventions like botulinum toxin and intrathecal baclofen, which can cause this pretty, again, dramatic decrease in spasticity. But if the patient has become reliant on that spasticity to provide some background tone, it can be pretty harmful. For example, let's say we have a patient that uses their quadriceps spasticity from a stroke to lock their knee when ambulating. If we take away that spasticity or reduce it, and the patient does not or cannot use their voluntary muscle ability in the quad, their knee is going to buckle. Or a child that uses some of the tone in the trunk and in the neck to support their trunk and head. By taking away that spasticity, we can cause a pretty severe problem with the child's trunk and head positioning. So again, this possible change in muscle tone, that these interventions that cause this should be combined with aggressive physical therapy. And the research on this is quite clear. So for interventions like intrathecal baclofen and botulinum toxin, and really any of the other interventions we've talked about, the drug therapy is really necessary to combine the drug therapy with aggressive and appropriate physical therapy. So this ends our discussion on muscle relaxants. It's a very complex issue, and you probably got a sense that these drugs are tricky to use, and dosage issues and method of administration all become important. But hopefully it's an area where drug therapy and rehabilitation are helping each other, are very synergistically linked, and by good drug therapy we can get better physical therapy and vice versa.